Well, welcome, and I want to thank everybody for joining us today. I'm going to spend a little time today talking about what healthcare looks like in 2021. Obviously, a lot of changes in the last 18 months or so, but we'll focus on the state of the industry and go through a couple of topics that I think will be timely and relevant to healthcare providers of pretty much any type. The presenters today, I'm Brian Hall, a partner in the Enterprise, Alabama office and also the healthcare industry line leader for the firm. Jose, you want to introduce yourself?
Yes, thanks, Brian. I'm Jose Aponte. I'm a healthcare partner out of the New Orleans office.
And glad to have Jose here. Appreciate it. So the agenda today, we'll be talking about five pretty broad topics. Obviously, the topic that's most on everybody's mind is the impacts of COVID-19 on healthcare and what we see going forward, both current and long term. We'll talk a little bit about the Biden administration. We're going to try to separate politics and personal preferences out as much as we can and just kind of take a bit of a scientific approach to looking at what is being formed in the first couple months of the Biden administration and what that means for healthcare. Of course, we'll spend some time on the Provider Relief Fund and then the forthcoming single audits and other options there. And then we'll talk a little bit about accounting to wrap it up. So let's start with the pandemic, with COVID-19 through today and going forward. Now that we're roughly a year plus into the pandemic, and obviously it continues to go forward with no end in sight necessarily. So the known impacts, we'll start with what we know, and then we'll go into what we think is going to happen. But the pandemic is the most expensive disaster in U.S. history. Just to put it into perspective, a recent Harvard University study looked at the total impacts, including the loss of productivity and the future estimated healthcare cost, and tagged that cost total at 16 trillion. So to put it into a little bit of perspective, World War II, adjusted for inflation, cost approximately 5 trillion. So enormously expensive disaster, including the federal response. And that survey, that study done by Harvard was actually before the most recent stimulus package and obviously any additional spending. So that number would probably actually be higher if it was done again. The anticipated gross domestic product loss in the United States for 2020 is about 8%. We won't have those numbers pinned down for a little while, but that is what everybody's anticipating right now. The worldwide average was about 5%. So the U.S. Obviously did experience a more severe repercussions of the pandemic than other countries on average. COVID was the third leading cause of death in the U.S. for 2020. It was the second leading cause of death for the elderly, ages 85 and up. We have greater than 500,000 U.S. deaths, and that number continues to rise, and approximately 3 million worldwide. Have an asterisk there because I think if we really knew the real numbers, especially from China and some of those other countries that don't really list true figures, that number would be much, much greater than 3 million. And really shockingly and saddeningly, 40% of all U.S. deaths were in nursing facilities, and that includes residents and staff. So it was, goes without saying, but it was specifically disastrous to healthcare providers. Some of the more notable impacts were devastating reductions in volume, especially outpatient, which have yet to recover. And we'll talk about the future impacts of this in just a minute. Deaths among staff, especially in the post-acute care world. truly unprecedented single-year wage growth, especially nursing, and we will discuss a little bit of that as well. Staffing and capacity issues, margin disruption and cash flow concerns, and supply chain disruption has been a key theme and key factor that healthcare providers have had to deal with this past year, 18 months or so. So a few key metrics from a recent study that focused, this is for hospitals specifically, but they considered several hundred hospitals across the country. The operating margins, when you take out cares, were down on average about 46%, which is obviously a huge number. The adjusted discharges down about 17%, emergency visits down 25%. Gross revenues, so top line revenues down about 5%. Total expenses were up about 5%. Labor on average up about 6%, and drugs up about 9%. So that's where we see, especially in the total expenses and the drugs, is where we see the supply chain disruption. And of course, the labor increases. That number would be higher if we netted out the reductions in FTE that were required, reductions in hours. Really, most of that is absorbed by the nursing costs, which have gone through the roof. As always, with anything like this that happens, there's an unequal distribution of the financial burden. The most negatively impacted across the country appear to have been the large health systems, notably the academic and charity facilities. And this is after you take into account the impact of the Provider Relief Fund and the other federal interventions that have gone on. So net of all that, the most impacted have been the large health systems, as well as the skilled nursing facilities for the reasons we just mentioned. And then ambulatory surgery centers and really any other type of healthcare provider that is entirely reliant on outpatient visits have really been devastated by the pandemic. And of course, a lot of this has to do with location and the individual state mandates and closures and all that goes into it. This has obviously been, the change has not been uniform across the country. So speaking a little bit about what the feds have done, again, the scope of this and the cost of this is unprecedented, and what it really, and the federal intervention is, of course, unprecedented as well. So the feds have really done, I think, of just about everything they can do to help healthcare providers in the last 18 months or so. Provider relief, of course, we'll talk about the CARES Act and where that stands. But that was a huge bill and a huge help. It didn't fully fill in the hole, but it definitely assisted healthcare providers of just about all types. There was a 20% Medicare DRG increase for any COVID-19 patients. The sequestration, the 2% Medicare sequestration was temporarily removed. The scheduled dish cuts that were supposed to go through were delayed. Of course, the payroll protection program was rolled out to not just healthcare, but businesses across the country. Also, the Medicare Accelerated Payment Program was tapped into on an extraordinary level, and actually that program only lasted about a month when they expanded it to cover, to allow for people to draw down those payments for billing disruptions related to COVID. So again, it only lasted about a month before they closed it down. The providers that got in early got theirs, but there were also a lot of healthcare providers that were not able to draw down Medicare accelerated payments. And then there was obviously a lot of state and local specific intervention that came through as well. On the clinical side, there's been an unexplained, and we've seen this in studies, and then we've seen this actually with our clients as well, but an unexplained nationwide decrease in expected admissions for chronic illnesses, most notably is mental illness, stroke, and chronic heart disease. So we'll talk about that a little more. That's obviously very concerning from a public health perspective. These are admissions that, in theory, could not be delayed, but we did see a pretty much across the board decrease in admissions related to those items. So there's a big question in the healthcare community about what's the ongoing ramifications of delaying those admissions, those visits, and kind of where do they go. So in the near future, so looking kind of out maybe a year or so, what does it look like? Cash flows is obviously going to have to be a big concern of healthcare providers. As the COVID-19 specific admissions continue to decrease, and we've seen, thankfully, a decrease in admissions and in days here in 2021. Also, the financial impact of that, of course, wanes. So that Medicare DRG boost that was added is going to go away, and some of that was kind of salving the wound, so to speak, for healthcare providers. At the same time, the wage costs are going to remain at unprecedented levels. And again, we'll talk about that a little bit more. Inpatient and outpatient volume has yet to return to pre-pandemic levels, and that kind of goes without saying. The CARES provider relief funds are exhausted at this point, and it's looking like no one can really predict the future, but any future additions there will likely be minimal. The most recent stimulus package did not really include much for the provider relief fund. There may be a final reconciliation process that may allocate some additional funds. We're unclear there, but it does look like the lion's share of the funding that's going to be available to healthcare providers has already been exhausted. At the same time, the payroll protection program, the so-called second draw, had restrictions that excluded most entities. It says many here, but it's really most entities were excluded from qualifying based on the tenets of that program. So when we start to think about what do cash flows look like as we go forward, really a lot of providers are focused and concerned about the repayment of Medicare accelerated payments, and that's definitely understandable. There's been some pretty significant lobbying to have those payments forgiven. Just personally speaking, I would be surprised if those were forgiven simply due to the inequities there, because a large number of healthcare providers were not able to get Medicare accelerated payments before the program shut down. So if it was forgiven, it would benefit those that were early to the table, but it wouldn't benefit all healthcare providers of all types. So we'll see what happens there, but I can definitely see an extension of the payments being on the table and some relaxed terms, but I do think it's highly likely that the healthcare providers will need to consider the impacts of cash flow and the repayments of that. Probably the most lingering item here, in my opinion, is the staffing level. So the healthcare providers naturally during this pandemic were managing the staff very closely and attempting to retain staff. And we'll talk a little bit more about this in some later slides. But kind of managing the way back down from the peak is going to be very difficult, absent those COVID and ICU volumes and the federal intervention and the other things that kind of allowed that to happen. So getting back to normal is going to be difficult. And also, healthcare costs are going to likely remain in an inflationary environment that is several multiples above the overall economy. In fact, we don't really have much in the way of inflation right now in 2021. Certainly with all the stimulus package and the everything that's been put out in the last year or so, that's going to happen naturally. But healthcare providers are already in a inflationary environment, a very significant inflationary environment. So we're going to stay above the economy for quite some time, which is very detrimental. Jose, let me bring you in here for just a second. The items that you've seen here or that we've just discussed, is that fairly consistent with what you're seeing in your practice out in the Louisiana markets and out west?
Yeah, Brian, that is pretty consistent. Again, I think the biggest key is the healthcare cost between the staffing and all other costs. I think that's gonna create a lot of issues down the road that maybe health entities are not preparing for right now because they're still trying to survive through this pandemic time. So I think that's going to be one of the biggest keys we see moving forward.
Absolutely. So speaking a little bit specifically to staffing, some of these numbers just kind of jump off the page at you, and it's just eye-popping. But the workforce, the pandemic created kind of a perfect storm for the labor market in nursing specifically. And it also increased the speed at which some of the changes we were already seeing came into effect. So there was, speaking to nursing, there was approximately a 300% increase in travel nursing demand from March to December of 2020, 300, so a threefold increase in demand. There was a substantial increase in nurses and frontline staff changing employers. So as a result of that, wages skyrocketed during 2020 on the nursing staff. On average, if you focus just on nursing, you'd see that the annual average wage increased from 25% on the low end to 50% at most facilities. And typically we've seen that this has been the larger facilities have been paying the most. So it is, again, a perfect storm in that you had to have nursing staff to be able to deal with COVID and COVID surges and potential surges. So that created demand. At the same time, you were competing against healthcare providers all around your area and healthcare providers all around the country from the travel nursing standpoint. So this is kind of our reality today. And going forward, that's going to be very difficult to get that under control when we no longer have federal intervention, that money to support it.
And Brian, I think one other area here that I'm concerned about we're going to have some issues with is specifically in rural or critical access areas. Are they going to be able to recruit and retain nurses after they've had these large wage increases doing travel nursing or moving to some of these larger systems? Is how are they going to be able to staff these rural areas?
Absolutely. So going along with that, even just kind of moving beyond wages, we've seen the pandemic has escalated and exacerbated recent employment trends. And a lot of this has to do with generational preferences as we see the next two generations moving into the labor market. The remote working environment, obviously not on the frontline staff, but on your administrative staff and those that can do it. We've seen a huge shift to that, and this is not just in healthcare, of course, this is all across the country. But that shift to remote working, and this may be a permanent trend. This may be a case where people don't come back to the office, or if they do, they come back and split their time between remote working and home. Enhanced protections for staff from a health perspective. I think that healthcare providers of all types should consider this a trend that's going to be there, in perpetuity, that the staff are going to demand that their individual health be protected going forward. Increased benefits, especially childcare. We're seeing a lot of that in the market, that the new the newly mobile workforce is going to demand increased benefits. And one of the big items there, again, is childcare. If you want to retain your staff, especially the young mothers, the childcare is going to be a big piece of that. And again, a more competitive environment. So there's much less loyalty to existing employers with the most recent 2 generations that we've seen. That's neither a good nor a bad thing. It just is what it is. But the ability to become more mobile and to shift jobs has kind of exacerbated that trend. So speaking to our earlier points, to what extent and when will staff be willing to go back to the quote unquote normal? So it's highly likely that the wage escalation that we saw in 2020, or highly unlikely, excuse me, especially on the nursing staff, can be normalized in the year that the pandemic ceases. So whether that be 21, 22, whatever it is, it's just really going to be, we've kind of built a problem here that's going to take a while to unravel. So how do we get our hands around our staffing costs, our nursing costs, and get that back down to a level that's supportable with our future revenues and more in line with our future revenues, and generate the margins we have to keep the doors open without severe staffing losses? That's going to be a huge concern. It's likely to take several years, I think, to kind of get back to a manageable level in staffing, and those several years will be without this federal intervention. So the margins are very likely, overall margins are very likely to be depressed for some time to come. And it may be, it's probably almost a certainty, I'd say, that the staffing costs and our wage costs have been reset at a much higher level than they were in the past. Hopefully we can get back down to something that's reasonable. That reasonable is not likely to be what we were paying before. So looking at the patient side, and this is first and foremost on all healthcare providers' minds, but to what extent and when will patients return to in-person visits? Most providers that we speak to anticipate a permanent reduction in inpatient admissions of some multiple, and a greater multiple there on outpatient visits. Telemedicine and in-home care, and I really think we're going to see a trend towards in-home care, including in-home hospitalizations. I think that's a model that CMS has already been looking into, but that's going to be greatly escalated. But those are going to be integral parts of the service mix for acute care providers, especially. If you are a acute care provider and you have the means to do so and have not been exploring these models and what this looks like, you may be a little bit behind the curve there. So now is the time to catch up, because it's quite likely that some of the older generations, this probably changed the way that they consume healthcare services for the rest of their life. So they're going to be looking more to telemedicine and anything that they can do outside of the 4 walls of the hospital and other acute care providers. And what will the lingering health impacts be? No one knows the answer to this because we've never dealt with this disease before. But we don't know if this disease has chronic lingering impacts. There's certainly some indication that that's the case. Also, will it have an unforeseen impact on those that were asymptomatic? Obviously, there are millions of people out there in the world that caught the disease and never knew they had it. So what are the lingering impacts there? As concerning to a lot of healthcare providers is what are the lingering health impacts on patients who delayed healthcare during the pandemic? So we're kind of go back to the mental illness, the stroke, the heart disease, those patients that kind of inexplicably disappeared from our facilities for a period of time, who have chronic illnesses. What does that look like when they return? And how do providers anticipate and adjust to these matters? is kind of the $1 million question here. So there's really two, it's completely unpredictable. There's really two scenarios. The existing healthcare model pre-COVID may have been permanently altered and pivot more towards a digital telemedicine in-home, kind of outside the traditional walls of the hospital and acute care provider approach. Or we may see that the previous model returns after probably an extended period of time. And really, time's going to tell on this one. It's going to be really difficult for healthcare providers, especially in the acute care setting, to plan for this because really either one of these could happen, and we have to be ready for it. To Jose's point, the rural and the safety net hospitals, so this includes the critical access hospitals, and even beyond hospitals, the clinics and the federally qualified health centers. And these facilities are going to face the steepest climb, back to quote unquote normal. Mostly that's going to be because costs are not likely to return to the pre-pandemic levels for a period of time for sure, but maybe ever, especially the wage and supplies costs. And the reimbursement increases in the federal intervention that has been offsetting these costs is going to evaporate. In fact, it's well on its way to doing so now in 2021. We don't really see any further legislation that's going to solve that. So we're going to be left, when this is all over, we're going to be left with a higher cost environment and a reimbursement environment that's similar to where we were before. And obviously the math there doesn't work. And as we mentioned, we're going to be dealing with a newly mobile and competitive workforce, which smaller facilities in the past have already had a hard time managing, and that's going to be, that's going to be increased in the future where you're trying to compete against larger facilities that have more resources. The safety net facilities, so the smaller community hospitals, critical access hospitals, other types of safety net providers and clinics, we're already facing margin erosion pre-pandemic. So this will be a struggle getting back to something that's sustainable, absent additional federal intervention, of course. And for hospitals, something that I haven't heard a lot of discussion about that I think is important is the potential impacts of the Medicare wage index. So when we get to a couple years down the road, when we get to the wage index being paid out based on 2020, 21, the pandemic years, what is the effects going to be for hospitals across the country? Well, the inflation in salaries in some of the larger states, so we think about New York and California, where we've seen wage costs go through the roof, even more so, is that disproportionate increase there going to permanently fix, so to speak, the disparities between those states when the wage index comes through? That I think that would, under the current model, would happen. So time will tell how the feds look at that. Jose, is this? I know you had spoken to the safety net and the critical access hospitals. Is this kind of align with what your concerns are and your clients' concerns as well?
Yeah, Brian, this is exactly what we're looking at and trying to figure out how to plan and prepare for.
Also, for the Provider Relief Fund and the Payroll Protection Program, the way these programs were created, and obviously I don't want to indicate that we don't want to be unthankful. The providers, I think, across the board are very thankful for these monies. But the way they were set up is that the providers were required to spend these funds within a very short period of time and also on very specific items. So it prevented, especially the safety net providers, from increasing their cash reserves. In response to this, we've seen a lot of providers allocate the funds to increase wages via It could just be shift differentials, hourly increases, pandemic premiums, hazard pay, a lot of different ways to do that. So they use that money and spread it to their staff, which I think is entirely appropriate and necessary at the time. But it also, again, it kind of set an expectation on the staff and increase their wages for this year, which is going to have at the time it was necessary, but it's going to have an unexpected and continuing impact on future wages, because you just can't really cut that back to where we were pre-pandemic in 1 year. It's going to take some time, and we won't have any more provider relief funding to support those increased level of wages. Excuse me. For all providers, the long-term impacts, it's almost a certainty that patients for sure, and I would even throw employees in here, and regulators are going to expect a higher level of safety protocols, and that's not free. That comes at a cost. Infection control is one of the big ones that we see out there. So there's going to be a higher standard of care for your patients, as well as your employees. And that's really an unfunded mandate. That's the world changing and around us, requiring additional expenditures, and really no money is being laid out there to support that. As we've said before, the federal intervention from the CARES and the payroll protection, all that must go away. We can't pay for this forever, so that will and must go away. And we're going to see tax burden likely to increase. From a provider perspective, probably we'll see that most directly is going to be in payroll taxes. We'll see the payroll tax rate likely to increase, but then also consider that double whammy when you still have elevated payrolls from compared to your pre-pandemic levels. On the state side, one of the perhaps beneficial things that's come out of this, just depending on your perspective, is that the Medicaid expansion conversation has come back to the forefront. We are already we expect, but we are already seeing several states, especially in the South, revisit Medicaid expansion. It just, given the cost of everything, especially on the state level, it almost requires this to happen in some form or fashion. And the Biden administration has been very open so far to having conversations about what that looked like. It could be block grants or non-traditional Medicaid expansion, but I think we are very likely to see several of the holdout states end up with Medicaid expansion in the near future. So speaking of the Biden administration, and again, we're going to try to separate ourselves from politics and just look at what's actually happening. It's very early as of the date of this webinar, but it appears the Biden administration is focused on stimulus. So we've seen our most recent stimulus bill was very large. There was some healthcare relief in there, but not much. We do see an additional one coming down the pipe, or at least being discussed, that may focus on infrastructure, but it may be framed up under the stimulus mantra. So we'll see where that goes. The Biden administration is very much focused on diversity. And when we say diversity, we don't just mean, ethnicity and demographics. It's really a diversity of thought. So we're seeing people from a lot of backgrounds. We're seeing people that don't necessarily have clinical backgrounds, taking roles that have been filled in the past by clinicians, and the exact opposite. The policymaker role is being filled by clinicians. So that's a little bit interesting. The Biden administration, of course, and it makes sense when you think about it, expanding coverages of the Affordable Care Act, so taking the quote-unquote Obamacare and trying to expand it even further. So we've seen that happen, and that will continue to happen. And then all of this has to be paid for, unfortunately. So we're going to see increased taxes. The most likely scenario that's being kicked around is capital gains taxes will go up. Corporate tax rates almost certainly will go up. as well as individual tax rates on the highest income brackets. So if we revisit the priorities of the Obama administration when it came to health, access and coverage were definitely at the top of the list for the Obama administration. They did try to focus on the safety net. However, the way that was funded and the way the legislation there kind of targeted the clinics, so the FQHCs and the clinics, it wasn't necessarily to the hospitals. The effect of the Obama administration's healthcare laws and goals disproportionately impacted or benefited urban facilities over rural. I don't think when you actually look at the rules, that I don't think that was by design necessarily, but the way things rolled out, the urban facilities were better off than the rural facilities. There was a focus on research and science, and of course you had the American Recovery Act, so Obama's own stimulus there, and the meaningful use monies that came and went. So I think it is very important when we look at the Biden administration and what's happening today to kind of think through what the Obama administration did and see if Biden is leaning towards kind of an Obama administration 2.0 or if he's going his own route. And I see a little bit of both in there. I definitely see where Biden is interested in expanding and tweaking Obamacare. But we also see a little bit different approach in terms of the people that he's putting in place to run the various agencies that deal with this. So it is very, very early on, of course, but it's very interesting to see how all this works out. And I think we can definitely take some hints from the Obama administration. So Jose, if you want to take over here, my voice is telling me a little bit, but
sure.
Talk about the provider relief fund.
Yep. So as Brian alluded to a few times during his pieces, one of the biggest things to happen as a result of the pandemic was the injection of this liquidity for all healthcare providers, known as the provider relief funds. The purpose of these funds were to reimburse healthcare entities for direct and indirect expenses related to preparation, prevention, and treatment of COVID patients. These amounts are there to be utilized to cover expenses, and for any amounts that you couldn't justify with the use of expenses, you can fund lost revenues. For anyone who's been following these provider relief funds closely and trying to build out their model as to how they're recognizing these payments, you'll know that the definitions of these things have changed. It still is a lot of very gray items of what is an allowable expense and what is a lost revenue, but it's taking shape, and I think we will still have some more changes, but and I'll go through a little bit more in the upcoming slides, but know that this is a very gray area, and there is a lot of open to interpretation. Through the release of HHS FAQs, they've defined what some of the allowable expenses are. So purchases of supplies, personnel costs, so personnel who are substantially dedicated to responding to COVID, COVID specific differentials, think about what jobs were created or retained even during the pandemic. So if your censuses are down, but you're maintaining your staffing levels in order to be prepared to respond to a mass increase in COVID cases, then those could be qualifying expenses under this. Thinking about any kind of hidden expenditures, specifically, there's a lot of hidden expenditures in your staffing. The one area around personnel to consider as well is there are limits on executive compensation and salaries, where you cannot use these funds to pay in excess of what they consider executive salaries. Some other types of expenses are mortgage and lease payments for medical facilities, certain capital expenditures, and as I said on the first slide, after you go through these expenses, you also can apply lost revenues. Lost revenues is where some of the bigger flip flops have happened in the various releases of their FAQs. As it stands right now, your lost revenues can be calculated either as compared to what your budgeted revenues were for the year, as long as your budget was adopted prior to March 22nd of 2020, or it can be compared to 2019, your lost revenues as compared to the prior year.
Right.
This created a lot more freedom. And also one of the changes is you don't need to reduce the reimbursement of healthcare expenses from the provider relief funds.
Yep.
So this created more flexibility in what can be used as a lost revenue.
Jose, let me interject here just a minute. So these are very good points. When we talk about the jobs, you really got to think about this from Washington's perspective. From a political perspective, again, let's try to separate ourselves from politics, but at least try to consider their perspective. Politically, it's going to be very difficult to sell to the public that these funds were covering lost revenues. So how they're trying to frame it, and if you read kind of between the lines of the audit reporting protocols and the FAQs that have been published, they want you to use lost revenues last, naturally. So they want you to measure any and all expenses, but they're also going to ask you for a lot of demographic items when the reporting comes open and statistics, and one of those are the jobs. So Washington wants to be able to frame this up as the bill, saved and created jobs. So the expenses that you end up claiming kind of need to follow that same story to the extent possible. So, when you read the guidance they put out, it kind of helps you understand their thought process, which in my mind goes a long way towards understanding what the future audits of this will look like and what they're going to be focused on. So again, lost revenues last, expenses first.
Thank you, Brian. Typical with any type of government grant funds, you do have reporting requirements. The reporting requirements for the provider relief funds are for anyone who receives more than 10,000 will have to report to HHS. There are 2 periods that HHS has initially marked as what reporting periods they want to have the information on. The first reporting period was as of 12/31/2020. So any usages of the funds through 12/31/2020, and then a final report on any usages of the funds from January 1, 2021 to June 30th, 2021, unless there's any type of extension over the usages of the funds. The initial report for the 12/31/2020 period was initially due on February 15th. However, the HHS site to report those amounts has only been open for registration. So if you receive these funds, you can go to the website and register your email address as one of the locations that has received funds and looking to report. But at this time, the reporting module is not open, and we don't have any indication as of this date on when the reporting module will open. I've included the website for the reporting. So if any of you have not signed up for the website, you may want to go do that, because they will provide updates as soon as the reporting module opens. As far as next steps for provider relief funds, I think it's important to continue working internally and with any advisors you have on quantifying what allowable costs and lost revenues you'll have for the period ended December 31, 2020. Again, once the reporting module goes live, you'll be able to report those. And once those are reported, we're not aware of any mechanism to go back and amend that. So if there's additional costs that you should have included in there. So it's important to make sure you've thought about and quantified all potential costs that are allowable under these funds for the first period, which is December 31, 2020. Work with your auditors during this time to ensure that your organization has the appropriate support to meet audit requirements. So we'll go through kind of what the audit requirements look like, but again, with any type of governmental grant received and spent, there's certain thresholds that once you meet them, there will be audit requirements. So make sure on the front end that you're quantifying these expenses and determining that they're allowable. You're working with your auditors to make sure that all the support's there so that your audit is as smooth as possible. And if your funds were not able to be fully exhausted by December 31, try to build out your mechanism for tracking the expenses from January 1 through June 30. Again, think about the expenses you've considered during the first period, the December 30th, 31st, 2021 period. And think about if there's any way to make that more of an automated or easier process so that when the June 30 period ends, you'll have those expenses either built out in your GL or through some other tracking mechanism that will save you some time and energy at the end. CARES Act audits. So as I spoke about earlier, you want to be working with your auditor to make sure that you have the required documentation. What would make you required for an audit? So for any government or not-for-profit entity that has expended more than $750,000 in these awards is subject to an audit under the single audit guidance. In this instance, expended would mean both your actual allowable expenses that you're going to report in the reporting module when it opens, and any lost revenues you've used to quantify usages of those funds.
Yep. And Jose, let me also add that the for-profits are not free of this requirement. They do have a separate option that we'll talk about, but the for-profits as well have to be audited, which is new. That's rare in the history of our country, and the money's landing in for-profit hands. So there will be a reporting obligation and audit obligation for for-profits.
In the 2020 compliance supplement addendum, the provider relief funds have been included in there. It is a new program and it's subject to 3 of the compliance areas, which are activities allowed or unallowed, allowable costs, and reporting. Again, the reporting module isn't open, so these audits right now would not be able to be completed and issued because you wouldn't be able to, an auditor would not be able to attest to you meeting the reporting requirements. One key area here is that for any entity with a year end prior to 12/31/2020, none of your 2020 year end expenditures will appear on your schedule of expenditures of federal awards. There will be a requirement to have a 2-year reporting during your next year audit, but this was not extended to 12/31 year ends. For-profit, as Brian had talked about earlier, you have the option of doing the single audit, or you have an option of doing a financial related audit of the awards conducted in accordance with government auditing standards. Option 2 is the preferable option, and this slide here shows you what does each option entail. So in a single audit, you have an audit opinion on the financial statements under generally accepted audit standards and government auditing standards. You have an in relation to opinion on the CFA, an opinion on compliance and reporting on internal controls, and a schedule of findings and question costs. If you go with option 2, you're doing a financial audit only on the statement of the HHS costs. And within that financial audit, you also have an audit on compliance and internal control and any kind of schedule of finding. So option 2, you're not opining on the financial statements under government auditing standards, which makes it a more preferable option. Some of the issues or areas we're waiting for clarity on. The AICPA has been in contact with HHS trying to understand how do these audits look for for-profit entities. Some of the questions they've asked is will the schedules be on a receipt of funds versus the expenditure of the funds? If the statement is actually going to be a gap statement or a special purpose statement, Will some of the other criteria that have been issued for governmental and for-profit entities extend to these, government and not-for-profit entities extend to these for-profits? So donated PP&E footnotes, the timing of expenditures, and whether any kind of audit deadline extensions that were granted to single audits also be granted to this other option. Additionally, the AICPA has sent some illustrative notes and financial statements that they are envisioning these reports looking like to HHS, but HHS has not responded to those yet, or there's been no formal release on what HHS's stance is on these items. These are just the two examples that AICPA has sent to HHS of potentially what these the statement of awards and statement of costs would look like. Again, these statements would include both your qualifying expenses and lost revenues that would qualify for the use of these funds.
Yep. So Jose, a couple of things here, just to, if we didn't make it clear earlier. So really what's going on is the feds have paid out roughly $200 billion to healthcare providers via the Provider Relief Fund. And then when you look at the sheer number of providers that exceeded the audit threshold, the feds just don't have the manpower to audit this. So they have, passed the buck, so to speak, to the CPAs of the world and our audit type firms to test this. So really what it boils down to is your auditors, be it us or whomever, are going to be testing your reporting to HHS. That's what the feds want. And that's why it was delayed until 21, because the reporting to HHS obviously hasn't happened. So you can't do it in 2020. So that's really what we're expecting. Do keep in mind for any entity, including for-profits, that once you hit that threshold, that 750,000, then all of your federal monies become subject to audit, not just the ones over 750,000. So you can see here that a lot of not-for-profit hospitals are going to be in this boat where you may get federal awards, but traditionally they've been below the threshold. Well, now that you got the provider relief funds, not only will the provider relief funds be subject to audit, but also the other ones as well. So you need to be talking through that with your auditors and getting an idea of what's going to be involved, because it is a very different and very more intrusive type of audit. There's a cost associated with that, but also keep in mind that any cost associated with the single audit can and should be included with the provider relief funding.
Thank you, Brian. And yeah, from an auditor perspective, we'd much rather our clients talk to us and ask these questions and work through it with us before we're out there for the field work doing the audit. And it's a lot more difficult of a discussion and more painful if we have to address it on the back end as opposed to the front end. And again, AICPA submitted some potential notes to HHS as well to go along with these statements. From an accounting perspective, for these funds, in the FASB world, if you're a nonprofit, there's specific guidance in ASC 958 for these types of transactions. So the Provider Relief Fund would be considered a conditional grant. At the time of receipt, you would record your refundable advance, which is a liability. And then as the conditions are met or substantially met, you would record the revenue ratably as those are met. So as the expenses at 12/31/2020 that you have qualifying and lost revenues you have qualifying, you would then recognize the revenue and reduce your refundable advance. For the for-profits, as you can imagine, for-profits don't have any specific guidance related to government grants. So the FASB does allow you to analogize to other FASB guidance that maybe isn't specific to for-profit. So there's some options. There's some other options out there available. Obviously, a for-profit could use ASC 958, similar to a not-for-profit, and recognize it as you incur the expenses. You can use International Accounting Standards 20, which has a very similar recognition as the terms, or as you meet the requirements. Or you could also use ASC 450, which is a gain contingency, which means you wouldn't recognize it until you can fully document that you've utilized the funds and that there's no potential issues of take back.
Yeah.
ASC 450 would be the least popular, because it would delay the recognition of the revenues and wouldn't match your revenue and expense
Absolutely.
time period. But it is an
Yeah.
option.
I think we're going to see just about everybody go with ASC 958, which will match the revenues with the expenses. I think it's just a cleaner presentation.
Correct. And in the GASB world, you would recognize it as a liability similar to what you're doing under 958 as an refundable advance or an unearned revenue. And then as allowable expenses are incurred or lost revenues are incurred, you would recognize it. In the GASB world, these revenues would be considered non-operating revenues or below the line revenues.
So I would like to highlight, before we wrap up here, that the presentation today is mostly just to kind of talk about where we are and as an industry and what we're looking at going into 21 and 22. CRI already has ample guidance on the website, and I would strongly encourage anyone that has any questions to go there. We will be updating that guidance, specifically targeting the single audits and the audits of the Provider Relief Fund as more guidance comes into becomes clear. But we wanted to thank you again for joining us. I know this has been a trying time, and on behalf of CRI Healthcare, let me say a heartfelt thank you to all the healthcare providers and our clients and even beyond. You have been on the front lines of this, and we are truly thankful for everything that you've done. Jose, thank you for being here. If anyone has any questions, you can reach us at this contact information, or obviously you can reach out to your specific CRI partner. If you have any general questions or don't have a CRI partner, you can contact us via the website, or you can email us at healthcare@cricpa.com, and we look forward and enjoy hearing from anyone and everyone, and we'll do anything we can to assist. So thanks again to everybody for your time, and I hope this was helpful, and we look forward to speaking to you soon.
Thanks, everyone.